Good morning, everybody. My name is Maria Gabriela Nasif. I'm a maxillofacial surgeon from Argentina, and today we have the pleasure to take with us in our global study club at Dr. Max Hyland, talking about artificial intelligence in CMF surgery. Dr. Max Hyland is medical school. He made medical school in Mainz, in Hamburg, in 1997. In 1996, medical degree. In 2001, he began dental school in Hamburg, and in 2004, he made resident in resident department of oral and maxillofacial surgery, University Medical Center, Hamburg, and for Edinburgh. Dental degree in 2001 and 2004, he began with habilitations in oral and maxillofacial surgery, University Medical Center, Hamburg, Edinburgh, and the specialization in oral maxillofacial surgery in 2004. He made the 2006 and 2006 senior consultant department oral and maxillofacial surgery, University Medical Center in Hamburg and Edinburgh. And associated as professor for oral and maxillofacial surgery, University Medical Center, Hamburg and Edinburgh. Vice head of department and oral maxillofacial surgery, University Medical Center, Edinburgh, in Hamburg, and sub-specialization in plastic surgery. Head in 2010, he became head of the department of oral maxillofacial surgery, General Hospital, Bremenhaven, Recklingheinz, and in 2007, specialization in dental implantology and in specialization in oral surgery. Fellow of Europe Board of Oral and Maxillofacial Surgery in 2008, and in 2017, he became head of the Department of Oral and Maxillofacial Surgery, University Medical Center, Hamburg, Edinburgh. In Berlin, actually, he developed his activities like head in a department of Department of Oral and Maxillofacial Surgery, Charité University Medicine Berlin, and he became part of the board election in member in 2019 of that two first 4 months. In 2024, he became chair of the board in AOCMF Europe and South African board. Well, welcome, Dr. Max, and well, it's a pleasure for us to share with all of us your experience about artificial intelligence. You can begin as you want.
Dear Gabriela, thank you very much for the kind introduction. I will try to share my screen as we tested before. Now it should work. Dear colleagues, it's my great pleasure to share my view on artificial intelligence in CMF surgery with you today. Honestly, and this has to be clearly stated, it's not a conflict of interest, but I'm a surgeon. I'm not a computer or AI specialist. So it's a perspective of a surgeon and not of the engineers. So if you have difficult questions at the end, please keep this in mind. So how to proceed? I think we are all using any kind of AI in our everyday life, because when I was young, I was looking at a map when I was driving, or my neighbor was looking at a map. Nowadays, we have a navigation system on our mobile or in the car that is automatically guiding us towards the fastest road to reach the target. And this is used in everyday life. And this is also done with algorithms who's calculating the road to take. And this is a good example how artificial intelligence and algorithms that are based on artificial intelligence can make our everyday life easier. However, the disadvantage of this is that our life gets more compact, more intense, more effective, because we are getting our brain free to do something else while something is calculating easy data in the background. So if you keep this example in mind, Google Maps, as an example, recognizes the target in seconds. It marks the target and it gives us the road to go. And we don't have to think, but it's something we could do by ourselves, of course. But the AI algorithm can do in the same or level as we could do ourselves, but much, much faster. The pioneer of artificial intelligence is John McCarthy, who is one of the founding fathers of artificial intelligence. He is credited with coining the term artificial intelligence in 1956. 1956, this term was made. He basically defined artificial intelligence as the science and engineering of making intelligent machines. McCarthy was a pioneering computer scientist whose vision helped shape the development of AI as a formal academic discipline. McCarthy's work had a profound impact on artificial intelligence, and his contributions laid the foundation for many of the advancements we see in AI nowadays. So what is artificial intelligence? How can we define this exactly? Artificial intelligence, AI, can be broadly defined as the development of computer systems or machines that are capable of performing tasks that would normally require human intelligence. The American National Standard Dictionary of Information Technology defined AI as a branch of computer science devoted to developing data processing systems that performs functions normally associated with human intelligence, such as reasoning, learning, and self-improvement. This definition emphasizes that AI involves machines performing tasks typically requiring cognitive functions which are naturally linked to human intelligence. And if we coming from our biology background as doctors who went to medical or dental school, we all know that in the brain we have neurons and they have a kind of a structure. And a typical neuron consists of three main parts. We have dendrites. These are branched extensions that receive signals from other neurons and transmit them to the cell body. So this is something you can combine with the incoming data. The cell body is the tool where the data is assessed, is weighted, is analyzed. The axon, the long extension of our neuron, that carries this information to the periphery by electrical signals away from the cell body. So this is the crucial principles even the artificial intelligence is working. It's in a comparable way to this. So the input in a neural network can be, in terms of artificial intelligence, could be any kind of information. It could be pixels, it could be values, or something comparable. The hidden layers are the brain, and these are neural networks, and they make the assessment of the incoming data, and this could result in any kind of activation. The more layers, the more complex this hidden layer structure is, the more information can be processed. Let's make a simple example to understand the basic principle. This diagram illustrates the basic process of a neural network and how weights are adjusted. In this example, we ask the network to identify all instances of the number 3 in a text. The green dots represent, in principle, the network layers. In the first imaging, as shown here, you can see that the network initially makes a mistake and only identifies the number 1. And this output is incorrect. It should be recognizing a 3. So it gets a weight of 0 because this is a wrong output. The second example is now the result is better. it identifies now a number 8. Of course, this number is numerically farther away from the 3 if we would consider. If we split the shape of the 8 in 2 pieces, it resembles a 3. So from the recognition point of view, the 8 is closer to the 3 than the 1 was. Of course, it's still wrong. But this is why it's not getting a 0 weight, it's getting a lower weight. Wrong, but closer to the 3. And of course, if the 3 is identified correctly, it is the high weight. This is what we want. So in principles, any kind of AI tool needs hardware, software, ground truth data, and data diversity. So why has it taken so long? Remember, McCarthy was in 56. And now we are 24. So it's a long time of developing these tools, and we are still at the beginning of this development. Of course, the hardware power, early computers couldn't handle the complex calculations that are required for AI that we are using nowadays. The data was limited. AI needs large data, diverse data sets, and they weren't available in the past. And of course, the algorithm, the software was not very well developed. So the early models couldn't replicate human-like intelligence effectively. And of course, it was very expensive, and hardware and software for AI were so expensive, inefficient until recent advancements. And the ground truth data are the reliable data sets that are needed to train any kind of AI, and they were insufficient in the past. And the ground truth data, and I will show you this and with some examples, they are usually manually in medical images, manually annotated to develop an algorithm. As of today, this is the German newspaper for dentists, and you just see an example of papers that were publishing there, and this was even the headline years ago. This was not recent, artificial intelligence in dentistry. So as of today, the current understanding of AI in healthcare in principle is that it serves as an incredibly powerful tool to support us as dentists, us as physicians or CMF surgeons. But we will not be replaced because at the end, we need our hands to treat our patients. So AI excels in processing vast amounts of data and can assist us effectively in diagnostics. So, but how exactly could AI support us, especially in the field of CMF surgery? If we look at PubMed and just look at AI and dentistry, it's an explosion of papers in the field of artificial intelligence, and this will be more in future. So, do we have to worry about whether AI will replace us or how can it support us? The gold standard in any kind of diagnostics is the physician are we ourselves. So how reliable are we in interpreting an X-ray, and does it make sense to use AI to make us better? Of course, we even when we had extensive training, and we all remember, for example, the dental X-ray courses during dental school, we are not perfect, and we can face challenges, especially if we have complex medical images. And of course, we can make our human errors. They can occur to we get tired, to fatigue, or to cognitive overload. This brings us to the question, how reliable is a physician when we are interpreting our images? And does it make sense to have AI beside us? And of course, the answer from my personal opinion is a clear yes. We will use these tools to be better. And if not we are doing, the neighbor behind will do, and he will be better. So AI can support us in reducing the numbers of misinterpretations by offering like a second layer of analysis and detecting patterns that may be overlooked. Now it should, yeah, here. So is even the algorithm can be better than we are. So when we provide an optimal data set, a AI algorithm can sometimes even outperform ourselves in specific tasks, like identifying anomalies on an X-ray. But it's important to note that this is not diminishing our physician's role, but because at the end we are responsible. The machine will never be responsible. It's our decision, our diagnostics. So the AI will help us, will support us, but not replace us. But we will be faster. Just remember the navigation system when we are driving our cars. We do exactly the same, but we are much more effective. And this will be the same in dentistry and medicine and CMF surgery. So, but how are the algorithms developed and what components do they really consist of? So, as said, to develop an effective AI algorithm for detecting any kind of pathologies, for example, in dental radiographs in panoramic views, we have to develop and we have to train the algorithm. So it's a training process. So the first step involves training data sets that have been carefully annotated by expert manually. So every single image has to be evaluated by more than one expert, and all the pathologies have to be marked. Then the algorithm with these ground truth data can be developed and trained. This is the base for all the algorithm that we are using in medicine and dentistry. And these annotations are crucial, and they have to be as precise as possible on a pixel level, that really what is not just marking there's a pathology, it has to be this is the pathology. Otherwise, the algorithm will not be able to detect the rules behind. Once the algorithm has been trained, we move on to test data sets. So we have an algorithm, we trained it with annotated data sets, so we know the data sets, and then we are sending new data to the developed algorithm and to make the algorithm better and better. So, and this performance, we say, when the algorithm is evaluating, analyzing new data sets, this is then something we can really compare to the performance of physicians, of dentists themselves. So then, and with each data set that is imported to the algorithm or presented to the algorithm, it will get better. And so by continuous training, the accuracy and the sensitivity and specificity will increase. That's the principle. So ground truth data set with manually annotated pathologies are used to develop the algorithm. And then we have testing data sets where the algorithm is making the analysis, and then this is trained or compared to the physician's reality. So, and we made this. It's years ago. This publication, detection of pathologies in dental radiographs, and we had a group of 24 dentists who evaluated 102 ground truth images, and this was the background. And then we had this was the algorithm developed, and then this neural network was trained with 2,900 anonymized images, and which they were annotated by 4 physicians. So 4 physicians, 2,900. This is a lot of work. So if you then are very creative and you're thinking, perfect, I want to make a startup and make a company out of it or sell this algorithm, then it is especially in Europe, it is crucial that the data sets that are used to train and develop the algorithm, you are allowed to use for commercial developments by the consent of the patients. And remembering 2,900 images from the past, you don't have the consent of the patient that you can make an algorithm and sell it for economical purposes. So this is you have the technical challenge and you have the challenge of the data you're using. So this is something to always keep in mind when you have an idea and you develop an algorithm, that you are allowed to use the data to make your startup idea going alive. So in this initial study, the performance this performance is usually summarized in the F1 score, and this was 58% is not really good to say so, but it was better than 14 of the 24 doctors. So nowadays F1 scores are around 90%, but at this time it was 58 and even better than the majority of the doctors. So a not perfect algorithm, better than the clinical routine. So these manual annotations that are used in these data sets, this in principle, that here you see that two physicians are making the annotations. This is double checked by a third one, and then you have a data set that can be used for the algorithm. So it's really a lot of manual work to develop something very digital. And someone has to do the job at the end. So, and these annotations are crucial, and this is a basic principle behind everything. For example, if you make these annotations with dental students, the question is, how well are they trained in detecting the pathologies? And are these really pathologies, or is this just an artifact? And so the quality of the ground truth data is really the key factor for the success of the tool you are developing. And of course, the segmentation of the mandible, or just the nerve canal, or just the maxillary sinus is something clear. This is just anatomy. But if you're looking at detailed pathologies, especially in an image quality of a panoramic view, where you have these over projecting of structures, this is something really to keep in mind. You can argue that a cone beam scan could be easier. Yes, it is, but you have a much higher volume of data than to deal with. So this challenge just shifts. Of course, you don't have over projection, but the volume of data you have to handle is much bigger. So just showing you in this, I hope it will run, how long it takes. So here's the DICOM data uploaded in this initial algorithm. Then, of course, it takes a little time that the algorithm is running over the panoramic view, looking where this image, let's say, characteristics of an apical radiolucency are detected. And once it's done, it's showing you, I see here, and here something relevant. Now the question for you as the physician is this really of clinical relevance, or is it just something, yes, of course, there is something, but it's not relevant. So this is the responsibility of the dental physician or the CMF surgeons. The responsibility will ever be with the doctors. This is just an example, and of course, apical radiolucencies is a critical model. It's not so easy, but just to show you the idea behind. I will show you other examples during the presentation. So, how does an effective collaboration between AI and the physician focuses on enhancing the workflow, then replacing our expertise? AI can assist us by rapidly analyzing large data sets. Remember cone beam data sets, not to oversee any pathology in the huge data sets. But it cannot only be radiographs, it could be even images or something else. And this allows us to focus on clinical judgment, interpretation, and decision making. And of course, we will be faster and hopefully with higher accuracy than without AI. The goal is for our AI to act as a support tool, providing a kind of a second opinion in our own environment, highlighting anomalies we have to clinically judge, thereby optimizing the overall performance and efficiency in patient care without compromising the human element of diagnosis, because at the end, we are the one talking to the patient. However, much more research will be necessary to really provide evidence how how helpful this will be in future. If we ask dentists, general dentists, max fac surgeons, orthodontists, conservative dentistry, whether they use AI nowadays for image analysis in clinical practice, the majority, no, not yet. But some do. And of course, this will be more and more shifting to monthly, weekly, daily, because it's coming and it will be an advantage and someone will use it and will be more effective, more reliable than the one without. You can drive a car without a navigation system, no problem, but the other one will be faster reaching the target. So if we see the patient journey in our departments, so we have several moments where we could be supported by artificial intelligence tools in principle. Of course, screening of patients. For example, if you have geriatric patients in their environments and they have a lesion in the oral cavity on the mucous membranes, if you want to have a clinical evaluation, they have to be brought to your department or your clinics, or you visit them in their environment. So screening of suspicious lesions. Imaging, as said before, if we do any kind of imaging like X-rays or clinical pictures. Treatment planning, all this virtual planning, whether it's orthognatic, it's recon, or even in trauma, all this treatment planning, someone has to do the segmentation, someone has to align everything together, design the specific patient-specific implant. And at the end, if we are honest to ourselves, it's always very similar what we are doing. So this could be, let's say, a little bit supported. Post-op assessment, whether we achieved our result that would be best for our patients. So compare the post-op imaging with the treatment plan. Did we reach the target? And of course, monitoring, for example, head and neck cancer patients, if they are not coming regular to our outpatient area, they can just send us pictures and we have a look, but supported with artificial intelligence, whether there's something suspicious or not. So if we look at our clinical routine every day, what we are doing, we have multiple possible interactions with any kind of artificial intelligence supported tools. So if we have the big advantage that our routine imaging has the very high standard. Of course, panoramic view is not a panoramic view because depending on the positioning of the patient, different than with the cone beam scan, but at the end, the image is always quite similar. And of course, if we have a pathology like here, this huge cystic lesion, it could be possible that an algorithm says, this is the pathology, this is something to be addressed. Intraoral imaging, as mentioned before, if we can get a picture like the above one sent, and we have an algorithm running through, of course, he will detect there something like 2 implants that do not look normal, because normally there should be teeth or nothing. There's something golden. But on the other side, if you look at the mucous membranes, there's a lesion. And of course, this could be something detectable by any kind of diagnostic tool. And of course, whether you make a clinical picture with your mobile or you make an intraoral scan in your office, any kind of image quality should be suitable for any kind of algorithm to be re-evaluated before you look at it. And of course, there are other specialities in medicine that are a little bit ahead of us. For example, the dermatologists are quite clever because every one of us knows I have a dark lesion on my skin, and is it a melanoma or should it be taken out? And we all know this challenge, even with our family and friends. And of course, the dermatologists are a little bit advanced to have, here is an example, an app for skin cancer detection. And of course, this is just a tool for the patient to be used by themselves. As you can see, you can download it in the App Store and you can use it by yourself. And this is something that could also be in theory possible for intraoral pictures, for example. You should go for professional cleaning as a very simple answer. So just look around in other medical fields. Others are a little bit ahead of us. And even if we look at our developments in diagnostics, and I'm personally, I am convinced that dental MRI will play a bigger and bigger role in our field in future because, of course, we skip the radiation exposure to our patients. However, we are not really used to see the pathologies in an MRI scan of the dental system in comparison to a panoramic view or to a cone beam scan because the image quality, as you can see, is different. But the information in the image is exactly the same. It just looks different. So, and if we jump to something new like this, we are not used to from our school and training, AI tools will make our life easier to use this different kind of information in the same way as we are using it if it was just a cone beam scan. And of course, if we see something like here in terms of treatment planning, of course, this is a double mandibular fracture. This is not the challenge. But to get something that will make if it's needed is the second question. But from the technical point of view, it will be possible, or it is possible, that you make an automated segmentation, an automatic repositioning. And just for an example, you can print out this virtually repositioned fracture that you have a 3D skull. You can pre-bend your plates. You can proceed digital to get patient-specific plates, whatever. So we have to start with simple fractures to have algorithm ready to be used in very complex situations. We always have to come from the easy situation that could be solved in the traditional way, of course, to have tools available for very complex situations, as in this example. And here, if we look again to other fields of medicine, here artificial intelligence planning and 3D printing for complicated hip joint revision. This is a very specific challenge for orthopedic surgeons if you have to replace the hip joint a second time, not the first time. And this is already published in 23 that this can be also planned with the support of artificial intelligence tools. And if you look at all our CAD/CAM procedures, patient-specific implants, in CMF surgery, of course, we will get tools supporting our routine. So in principle, if we look at this, the technical background of artificial tools is some kind of a network. It could be like fully connected neural network. It could be convolutional neural network. These are different principles how these networks are built. And of course, the principle at the end the effect is similar, but the physical principles are a little bit different. These are questions I will not be able to answer in detail in the discussion. However, from the surgical perspective, where can we use this? Of course, we can use it for classifications, for segmentations, to get a primary report out of this, to get some kind of image enhancement or generation of something like this. And at the end, we want to use it for diagnostics, for 3D reconstructions, for monitoring, for screening, for virtual planning. So at the end, this is something I'm coming from the right side, the engineers are coming from the left side, and at the end, we want to have reliable tools that we can use in routine. And the principle for all these tools, as mentioned before, is ground truth data, annotated data sets, developing and training of the algorithm, and then we are ready to use it in clinical routine. So we want to have tools that assist ourselves in detecting pathologies, minimizing misdiagnosis, enhances the patient's trust in our competence, make our treatment process faster, streamline the workflow, make us more efficient. Another example for automated detection and segmentation in 2D images, panoramic views, is this study and the group in Nijmegen by Schenk and Stefan Berger is one of the pioneers in artificial intelligence in CMF surgery. They had this great keynote lecture at the European Congress in Madrid 2 years ago. And of course, since then, this group is still very active. In this study, 2,000 panoramic radiographs were randomly collected from different clinics, and They had a special network architecture that's called MaskR CNN that was used in the study. And then they had first the detection and to detect regions of interest and with potentially anatomical dental structures. So the simple challenge was, where are teeth? Yeah. And these specific dental components or abnormalities for an algorithm, even a dental implant is not looking like a tooth. So this is something, let's say, abnormal. For us, it is clear it's an implant, but the algorithm has to learn that this is something looking different than the tooth, but not a pathology itself. So this has to be make clear with the detection. Then in the second step, you go for segmentation and you say, okay, this is exactly the tooth. And after segmentation, a rule-based post-processing step is applied to ensure that the results are consistent and feasible for clinical use. So at the end, it has to be all double-checked. That's up. As you can see here, first, where are tooth-like structures? As you can see here, this is what the algorithm is the first step. And coming back on the right side, you see this F1 score. And here we have values above 90%. And of course, this is for the 95% is for teeth, crown, implant, filling, and root canal. And the lowest detection rate was obtained for root remnants with 80%, because a root remnant is looking like something, but not like a complete tooth. And of course, this is confusing the algorithm. What is this? And for us, it's clear. For the algorithm, it has to be learned. And the second step is then here that the teeth are labeled correctly. And again, for the teeth itself, it's easy. And whichever system you are asking the algorithm to apply, it's just an application of a rule, so it's easy. But to consider even a dental implant not looking like a tooth, but like a tooth equivalent, this is something that could be a little bit challenging to be done on a high accuracy level. Another very nice example published by this group, the automated prediction of extraction difficulty and inferior alveolar nerve injury for mandibular third molar using a deep neural network. So the first challenge is to detect the mandibular third molar. This is the first challenge, that these are identified on the image correctly. And of course, then we have to classify how this mandibular wisdom is located in the mandible. And of course, we have some existing classifications. So the algorithm is trained to determine whether we have a vertical eruption, we have a soft tissue impaction, we have a partially bony impaction, or complete bony impaction. And of course, this is then the classification result and the risk of inferior alveolar nerve injury. And these are, you see the F1 scores again, of course, not perfect, but the challenge going back, this is a quite difficult challenge for on tools like this to identify, to classify, and to predict the risk of nerve injury just as an algorithm. And of course, the entire prediction process, including the detection of the inferior third molar, the classification of the extraction difficulty, and the likelihood of nerve injury. And of course, you see here this confusion matrix, where that's, for example, 20% of partially bone impacted teeth were misclassified as complete bony impacted teeth. So it's not perfect, but at the end, it's just a question of training to make the algorithm better. But in principle, it's possible. And this is amazing that a software can predict something like this just from a panoramic view. So another nice study, and you hear, now you see really the amount of images that are used in these projects, mandibular fractures on a panoramic view. So 6,404 panoramic views. 1,624 had a mandibular fracture, manually annotated. Just consider the time that you would use to make an annotation of 1,600 panoramic radiographs. Then the algorithm was trained and validated, and then it was used. And here you see that this kind of algorithm is detecting the fractures correctly. You have a double fracture, not really displaced, so not so easy to detect. So this is working. And here again, we're coming to the F1 score again. The lowest classification accuracy was with the coronoid fractures. It's a rare fracture on the panoramic view. And the highest classification performance was with condylar fractures. And it's perfect. And if you imagine what we all see on a panoramic view, and of course there are much other pathologies that we are not used as dentists or CMF surgeons. For example, carotid plaques. If it's a lymph node, is it a carotid plaque? Is it a relevant carotid plaque? Do I have to send this patient to a vascular surgeon? What is the next? So they are present in up to 15% of panoramic views. And of course, in 7% of calcification, there's a stenosis of over 50%. So, and we are not trained to judge or even detect these kind of pathologies, although the information is there. So again, this is a great tool to use something on an algorithm level to make us better. And here you can see, again, we have the DICOM data that have to be annotated. We have to train the algorithm. And then, of course, we have to double check whether it's really working or not. So again, the F1 score is the relevant tool. So, and this can be done with all the information we have on panoramic views nowadays available. And here you see the overall plaque detection rate. The F1 score was 88%. And so it's confirmed the hypothesis of the study that a deep learning algorithm can assist us in detecting carotid plaques on a panoramic view. However, which plaque that is detected is relevant and has to be double checked. This is the next level that could be included. Another tool in panoramic views that is usually there, but we don't recognize, is osteoporosis. And osteoporosis can be relevant for us because the jawbones, if a patient has osteoporosis, the jawbones are affected. It's a general disease of the patient. And if we want to put implants, we should know whether we have an osteoporotic bone or not. So, and in the panoramic view, there are some indices that we could use to detect it, but no one of us is using them because they are a little bit complex. It's not reimbursed, but we can use the panoramic view information to get hints for osteoporosis in a patient using, again, some tools based on artificial intelligence algorithms. And this is here with 250 panoramic radiographs with osteoporosis and a control group with 250 panoramic views without osteoporosis. And then you develop your algorithm to detect this. And this is a lot of work to do so. Again, you see here the F1 score with 74%. It's not perfect, but it's not bad. And it's clearly better if I judge myself whether this is an osteoporosis on the panoramic view or not. Again, a proof of concept, and further studies are needed whether this approach is really helpful or not. An idea that I like very much is the analysis of images made by your mobile from the mucous membranes to early detect squamous cell carcinoma and to not let all these patients come to our clinic when there's nothing relevant in the visible. So I just want to see the patient where there's really a pathology that has to be biopsied, and not just an aphthous lesion or something like this. So this, I see a huge benefit if we get something reliable to use. And of course, there was some work done and with clinical pictures, and they have to be annotated again. And you have to say, this is a leukoplakia, this is a squamous cell carcinoma, this is nothing. And then you can start to develop your algorithm. And this was done with the SWIN transformer network. This is again the technical tool. And here you nicely see that the area that looks a little bit, let's say, abnormal was clearly detected. And then you really know, okay, this is a patient that has to come and we have to clinically double check the pathology. And again, a very high F1 score in this study with more than 98% of accuracy. And this is one of the projects that could get a startup in our unit. This, we call it MucoAid, just a tool where you upload the imaging and you get a judgment whether this is something that has to be seen by a professional CMF surgeon or an oral surgeon or not. But this is still ongoing work. But technically and in principle, it's possible. Of course, our routine is 3D. And 3D means, of course, we do not have overlapping of structures in our images, but we have much more data to deal with. And of course, we all know this workflow of virtual planning where we upload our data, make the segmentation, and then we start our planning. And of course, this can be clearly supported by any kind of algorithm using artificial intelligence tools, even for the segmentation to make our life faster. And whether we use cone beam scans or we use MRI scans, the principles is the same because the information is there. It just looks a little bit different, but it will be there. And of course, what I've shown you before, that we can detect mandibular fractures in panoramic views, we can also detect them in cone beam scans. Of course, even for us, it's easier to see them there, but of course, it takes more time because we have to look at more data to identify the fractures. So here, of course, the tools can be really helpful to manage larger volume of data. So again, a stepwise procedure to develop an algorithm here that was called JawFragnet. This was the name of the algorithm, and it was trained in 3 stages. And of course, we have to first to define what is the mandible and to have a mandible segmentation. Then we have to see where there are fractures and is displaced fractures or non-displaced fractures. And so step by step, the algorithm was getting better and better. And here you see just examples. And in A, you have a non-displaced fracture. In B, you have a displaced fracture. You have an incomplete mandible in C. And if we have a patient who had a surgery before, the anatomy is completely different. And of course, this has to be also detected by our algorithm. And of course, we have to be really careful with false negative and false positive analysis like in E and F. So, but in principle, it's working. And Journal of Dental Research, where this was published, is one of the highest journals we have in dentistry. So this is really very advanced and high-end scientific project. And here is the precision and sensitivity. So it's quite good, and it will make our life easier. What I like very much is if we just get a picture of our patient from home, and we have much more information in these clinical pictures. We can these oral hygiene parameters. We can see this is a patient who has to come to an urgent recall for professional cleaning, or we have a mucous lesion. So I'm sure this will come clinical routine in the near future and will have a great impact on our patient care in the next future. And with this, thank you very much for your attention.
Thank you so much, Dr. Max. We are very excited with this topic. And we have questions. I'm Belinda Beltran, oral and maxillofacial surgeon from Mexico, and I'm very happy to be here. And I want to thank all the people from Ecuador. Hola, amigos. Thanks for being here with us. Thanks, Jorge, for make this true. And there are questions here. First, from Lucas Ritaco. What is the minimum number of images to train an image algorithm?
Yeah, it depends a little bit on the clinical question you're having, but we are talking about hundreds, and the more the better. So as you've seen in the clinical studies I'm showing, the minimum was around 250 annotated data sets up to more than 1,000. And with mucous membranes lesions, our challenge, honestly, we have, I think, around 10,000 data sets in this MucoAid project. But the problem is we have normal mucous membranes, normal findings, and we have a huge variety of pathologies, and not all the pathologies are squamous cell carcinoma. So the more diagnostic varieties I have to consider, the more data I need. So because I have to train the algorithm to detect a squamous cell carcinoma, a leukoplakia, an inhomogeneous leukoplakia, a lesion. So I have multiple pathologies, and for each I need training. So, and the more complex the clinical question, the more data I need. Let's say, in other words, on a panoramic view, fracture, yes or no, is a simple question. Mucous membranes, squamous cell carcinoma, yes or no, is a very complex question because not all the pathologies are automatically a squamous cell carcinoma. So depending on the clinical questions, but we are talking about thousands, not 10, 20.
And there are another question is from Padraig McGavin. Hello, how do you think AI algorithms can make it easier? That is currently is not virtually plan and execute complex reconstruction surgeries such as double barrel, fibula-free, flap mandible reconstructions. Thank you.
I'm totally with you, because when we start the planning of any kind of recon, we are all having the same, let's say, models in mind. For example, double barrel, you have this vertical challenge, and you say, okay, I want to have a double barrel. You see the defect, and you have already in mind, this will be my possible best solution. And because when you look at all your planning patients or your patients you did, you have some kind of always same principles you're dealing with the defects. And if you cluster this type of defect, I like this way of reconstruction most, and this is my first choice, second choice, third choice. This is something you can train. And then the algorithm could already prepare the data for you, or even just double check for you, this will be possible or this doesn't make sense. And to give your input, what you have in your brain, in your experience, to the algorithm. In this case, I will do this. I will do this. So with each case, you're telling the algorithm, this is my solution for this defect. The algorithm gets better and better. And you, as the surgeon, gets more and more trust to the software that it's really helpful for you. So at the beginning, you have to, like when you get a new dog at home, at the beginning, you have to invest a lot in educating and training. And by getting older, the fun aspect gets more and more because you can rely and you trust. But at the beginning, it's just a lot of work. And it's a little bit the same. Yeah. But at the end, what you have in your mind, you have to tell the algorithm more once and once and once. And at the end, he knows what you want and what you think, and then you trust it. And this is like the journey, how to make these tools. And of course, if someone else developed an algorithm, we don't trust. I don't know who this algorithm was developed, who was giving the input. But at the end, it's something you have to adapt. You can train for yourselves. And in 5 years, we will use these tools, I'm sure.
Thank you.
And sorry, one more comment. And I see a big field in orthokinetic planning, because orthokinetic planning is the same, and it's even more complex because occlusion is just one piece of it. Occlusion is not difficult, but the aesthetics, what is the perfect movement in this phase? Every one of us has an idea, this millimeter, this rotation, but to give an idea that we train an algorithm in this patient, I would do this, and this patient was 100% satisfied afterwards, and this was only 60% better. So this solution was the better one. And to develop algorithms that give us an idea in orthokinetic pathologies, not the occlusion, easy. But the aesthetic movement to fulfill the criteria or the expectations of our patients, this will be something that will really make our life much more easier. And then if you consider surgery first, which is much more complicated from the planning from the orthodontist, and this will also be a very, let's say, effective tool if something learns from the patients we have already treated, and we know the result, and we know which result was perfect and which result was not perfect. And this is something we will make our life much easier and much better in future.
Gabby, you wanted to say something?
No, it's okay. I agree with that. I wanted to ask about total temporomandibular joints replacement. Well, I think that here we have a question for Marcelo Figari too, and that it's did you have any experience with all supporting with the virtual planning of custom-made TMJ prosthesis?
With
If you have
TMJ
some experience about that,
we have the experience of doing virtual planning ourselves with the web engineers, but not with artificial intelligence, because as when we're coming back, you need a lot of data sets to train an algorithm. And I don't know, we do TMJ replacement, let's say, twice per month. So let's say we do 20 per year. So to get a data volume that is really a ground truth to train an algorithm will take, if we're looking only at our cases, will take a very long time. So if we make it internationally and we all collect our data and we have, maybe we share all the same company and we collect all our planning, then we could develop a tool together. But to come to a sufficient number of cases to train an algorithm from a single institution perspective will take a very long time.
Thank you.
Thank you. Yes, continue, Delina.
Yes, we have another question from Kaylan Abdel Galil. Do you think AI will assist more in a hard tissue or soft tissue pathology? What do you think?
I hope in both. Because honestly, if we come back for orthognatics, the bone is one piece, but the soft tissue prediction, the patient is asking, how will I look afterwards? And then we can tell you this will be your bone. But the soft tissue, we don't know. It could be something like this. But on the other side, we have all our postoperative images of the patient, pictures and even cone beam scans or X-rays. So we know the result, but we have no tool that's saying, okay, we have some, in the case designer from KLS or even Materialize, we have some idea, but it's not really reliable and trustable. But from the patient's perspective, the soft tissue outcome is the relevant one. Of course, they want to bite and they want to look better. And so I see that the soft tissue prediction is the greater tool for AI because the need is much bigger and it's much more relevant for the patient. And it's much more complicated because if I move the mandible 3 millimeters in a segmented bony mandible, I know how the DICOM image will look like when I add 3 millimeters plus. But how will the soft tissue chin look? I don't know. And the software doesn't. And this is something that is really relevant and needed. So I see a bigger field for help from the soft tissue perspective.
Do you think that it's more predictable and more accuracy for soft tissue? Okay.
Yeah, we hope so.
Okay, great. I have another question, Mark, from the other persons here. They are asking for the applications for sales, like you show of a tray to try it. Have you asked if there are already applications for sale like this or tries to try it?
Which application? I didn't get it. Sorry.
Yeah, I think what is the AI program that you
AI program. Yes.
This is not. These algorithms are like this is not a software. The algorithm is the software behind. It's in languages we don't know. But if you have the software behind, and then you have like the app software. For the example with the dermatologist, you have the surface for the user. So, but the AI is behind. So these are two different worlds. The algorithm that is making the analysis and the software's interface for the user, for you as the dentist, CMF surgeon, or for the patient. These are two different worlds. And honestly, there's not the one and only solution at the moment. So you've seen this picture with all these different ideas or principles of a neural network. So these are very complex software algorithms running. This is something completely abstract. But for us as a clinician, I need a software surface where I can upload my data and I get a feedback. What is happening behind? It's not the surgeon's world. It's a AI world. It's something different. But we need the interface. And from all these softwares I've shown in my, at least from the projects I'm involved, nothing is officially commercially available on the moment, because if you want to make it available and you will use it in Latin America, it has to be certified. So it's not like a scientific project or like a little startup idea or whatever. If you want to make it open use, it has to be certified, reliable, and at the end you're responsible that it's working. So this is the next level. At the moment we are like playing around, yeah.
Okay.
But I will not sell anything
So-
because it's.
So in this
Yeah.
moment, we don't have a supplier that we can buy the program or some.
No, at the end, it's something. This is not available at the moment.
It's not available.
Okay,
Okay,
we are
we have to
waiting
Also-
to develop. We are waiting to develop one. and
Yeah, exactly. It's a dynamic
We're
field, but
waiting
it's yes.
We're
Yeah.
waiting for that. Okay.
You know what? There are participant Angel Federico Avila Ventre. He has he raised his hand. I don't know, Mauricio, if it's possible to get the access to his microphone. I don't know if he wants to ask something in person.
The micro.
I open the possibility to make the question.
Thank you, Mauricio. Angel, can you open your mic, please?
Was an error, Dr. Belinda. I just
Okay,
he wrote in here.
okay. Oh, he wrote, I was an error, did it? Oh, was a mistake from him. Okay, no problem. And
Yes,
I
he
think
said
we
that.
are all set.
Yes. Do you have any more questions? No.
No, you know what? I did an exercise and I made a question to the artificial intelligence and how to be more competent than the artificial intelligence. How can I be better than you? So and answer me, you know. So, and says, become more competent than artificial intelligence is a challenging task science since artificial intelligence systems are designed to excel in specific domains and perform complex tasks. However, there are several areas where human capacities continue to surpass AIs. Here are a few ways. So, develop unique human skills. Focus on developing skills that are distinctive to humans, such as creativity, emotional intelligence, critical thinking, and complex problem solving. These skills are often challenging for AI systems to replicate. 2, adaptly and learn fast and furious. Embrace a growth mindset and cultivates a willingness to learn and adapt to the new situations. And we have to work in ethics because the artificial intelligence cannot manage the ethics. So it's very interesting be doing like this we are doing now. I mean, be in contact with people, sharing ideas, sharing the knowledge as you are doing, Dr. Max. This is the humans do. And another thing than the artificial intelligence cannot do is to share the knowledge. So I think this topic is just amazing. We are growing, learning, and I'm very, very happy to be part of this study club this time. And I hope to see you soon, Gabi, Jorge, Rafa, and Max in another time in person to share as the humans do.
Yes, it was great. Thank you very much, Max, for share with us your experience. For us, is amazing. We develop with computer-assisted surgery actually in our hospital, but we have to continue with increases. And I think that artificial intelligence is brilliant and is the future, and we have to try in all of that. Thank you very much. Thank you, Belinda. And
Thank you.
And
Muchas
if we
gracias.
muchas gracias. And thank you for your support, Mauricio. And well, we can see you in the next Global Study Club. Okay.
Thank you.
Thank you everyone for your participation. Thank you very much.
Thank you.
Bye.
Adios.